So one more time, show of hands, everybody who's been CPR trained. Everybody has healthcare provider CPR? Okay, cool. We're going to talk about some things that are maybe a little bit outside of our scope and practice, but if you know me, you know me. I'm always talking about educate yourself, right? Learning's what you do for yourself, education's what we do to you. So right in front of me, I have pig lungs and a pig heart. Currently what you see, this is snout end, this is towards the bottom end of the pig. It is intubated with an ET tube. So what you would know about that is that we've taken over the ability to breathe for this person, okay? When we do so with a bag valve mask. There's obviously the bag, there's a valve in here. Normally on a human face I would have a mask, except that I have intubated my patient, so I will connect it to the endotracheal tube. So when you ventilate with a bag valve mask, for my students, how do you squeeze the bag? Talk to me.
Softly, you don't want to press too hard and cause damage.
Thank you. Very gently, and I don't want to cause damage. Where do my eyes belong when I use my bag valve mask? Sonia?
On the chest.
On the chest. Why are my eyes belonging on the chest? Mo?
Certainly you're going to watch the chest is going up, whether they're getting oxygen or not.
I want to make for sure I see chest rise, and I also want to stop squeezing the bag or stop the ventilation when I see that chest rise. What's a major risk I run if I overventilate my patient forcefully like this? I'm going to cause barrel trauma. If I'm ventilating my patient like this, have you ever breathed like that in a healthy state?
No.
No. Anytime you've ever saw someone breathing, it's been in an extreme state, right? There's another stressor, or there's a reason why, a sickness, or you're running from a bear or something like that, okay? So why would we do that for our patient? We would not ever. We're trying to help them get better and recover and leave us and move on to a healthy, productive life, right? So when we ventilate, we're going to do so slow and easy. We have an ET tube placed, an endotracheal tube. So I'm going to give one breath every 6 seconds. That's the American Heart Standard, okay? In the hospital, and most of you are going to work in the hospital, some of you will work in the clinical setting, when we're ventilating a patient that has an endotracheal tube placed, compressions keep going at the same time that the patient is being bagged. Compressions are going to keep rolling out. Let's talk about this. Now, do you see why compressions are so important? The correct depth, the rate between, what is the rate? 100 and 120 a minute, right? Because if I'm compressing the heart, what else am I compressing?
Lungs.
The lungs, the rib cage in the lungs. Okay, so when we're ventilating our patient, you can see this. Can everybody see that lung tissue? That it's relatively easy for me to bag. But tell me what you notice about the lung tissue as I'm ventilating. What do you see, guys?
Expanding.
And then?
Deflating.
And then it's deflating. So how many times did I tell you I'm going to squeeze the bag or breathe for my patient when I have the ET tube placed? One breath is 6 seconds. Now, when I was just speaking about that and telling you that information, I was continuing to breathe because I wanted you to see how much they rise and then they fall right back down. So we take in a breath. What do our lungs do with that air? There's gas exchange. We give off some CO2 and other things, the waste products, and we take in oxygen, right? So every time I do this, it's happening. When I do that and relax up, what's not happening? Gas exchange. We want the expand and we want the little bit of expansion to stay, because as long as the alveoli, the little air sacs in the lung are open, the gas exchange is happening because the little tiny vasculature that runs over the alveoli is where the gases are going in and out. Okay, just like y'all do when I say class dismissed and you run for the door. All right, so what I want to show you is something really neat. It's called positive end expiratory pressure. What's it do? It puts a little bit of that, it keeps a little bit of that volume in the lung. So when I put this on, you guys are going to be like, wow. So make for sure you have a good point of view to see it. I'm going to start with 10 of PEEP, and I want you to see how it holds that open. Okay, all ready for this? Mm-hmm. See how they're staying up? Look at the pinkness. Look at the expansion on that lungs. That's 10 of PEEP. Look at how gorgeous those are. Take it off. Let's let them go all the way back down. PEEP valve. Would you say that's less than half? Okay, here's 20 of PEEP. Okay, lungs are totally. Third squeeze, right there. That's my third squeeze, and look at all that gas exchange that must be going on in those lungs if they were alive. Look at the tremendous amount of recruitment I have of alveoli right now. Pretty awesome, isn't it?
Hey, Robin,
Mhm.
so do they carry that piece like on ambulances now, like the paramedics?
This piece is not in every ambulance and on every helicopter, probably every helicopter, not every ambulance. And it's not in every emergency room. That's also another reason why I wanted to bring this here to us as PCTs. We don't often, as patient care techs and MAs, have this bag valve mask in our hand. Usually it's the respiratory therapist, or it's the intensivist in the hospital, or it's the paramedic, or whomever else, the nurse possibly. But if you get the bag valve mask in your hands, like I taught you from day one, I want you to understand how to use it, because it can be used inappropriately. If somebody wants to come behind me, you can take a picture of it if you want to. You can take an opportunity to ventilate the lungs. And then I'd like to go on and show you the heart. Come on, PCT students. All right, so immediately now when we're looking at the heart, what do we see? We see the right atrium, and we see the big workhorse part of the heart, the left ventricle. Why is the left ventricle so big?
Because it supplies to the body.
Because it's the one pumping the blood out to the body from the tip of your head to the to the end of your toes, okay? Before I cut it, what is this piece? Superior vena cava. I'm pinching it at the wrong spot. But here I'm gonna cut it open. Do you see this? So these are chordae tenendinae, and they will help the valve open and close. This, can you see me putting my finger in there?
Yes.
That is going up through the superior vena cava. Look at how big that is.
Robin, how big is our heart in comparison to that heart?
Your heart is about the size of your fist, so pretty close. But look at that. That's why in trauma patients or in blunt force trauma, we have to worry about that vasculature being damaged. If that bleeds out, how am I gonna, short of being a surgeon, how am I gonna stop the bleed and keep the blood in your body circulating the oxygen, which we know is what keeps life going, right? How sweet, look at this blood still, his heart still has blood in it.
Wow.
Okay, so here's the right atrium, superior vena cava, and here goes down to the left ventricle.
Well,
You notice how thick the muscle is right here. Look at this. Okay, so inside you can see the inside of the left ventricle. If you can see all those tiny little heartstrings is the funny name we give to them, but those are the chordae tenendinae. Those are what helps the contracting muscle pull that valve open and closed. That's how your blood gets into, that's one of the ways your blood's coming into the atrium, down into the ventricle, out to the lungs, then back into the atrium and into the left ventricle and out into the body, right? So when we say heartstrings, that's what we mean, only they do have a medical term,
wow.
right?